The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the American Brain Tumor Association's free educational webinar series. Thank you for participating in today's webinar. Today's webinar is on advances in the treatment of glioblastoma using Tumor Treating Fields. The webinar will be presented by Dr. Jennifer Connelly. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Dr. Connelly will answer questions at the end of her presentation. In the next few days, you will receive an email asking you to take a brief survey to evaluate the webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. Today's webinar is being recorded. The recording will post to the ABTA's website on the Anytime Learning page shortly. Registered participants will receive the webinar recording link in a follow-up email message once it is available. Let's pause for a moment so we can begin our webinar recording here. The American Brain Tumor Association is pleased to welcome you back to our webinar series. Today's webinar has generously been sponsored by Novocure and will be discussing advances in the treatment of glioblastoma using Tumor Treating Fields. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Jennifer Connelly. Dr. Jennifer Connelly is an Associate Professor from the Department of Neurology at the Medical College of Wisconsin. She is triple board certified in internal medicine, neurology, and neuro-oncology. Both her clinical practice and research interests center around neuro-oncology and novel magnetic resonance imaging, MRI, techniques. Thank you for joining us, Dr. Connelly. You may now begin your presentation.
Thank you, Christine, and thank you to the American Brain Tumor Association for inviting me to be part of this wonderful educational opportunity. And thank you to our audience members for joining us this afternoon. So today we are going to be talking about the recent advancements in the treatment of glioblastoma using Tumor Treatment Fields. Before I get started, here are my disclosures. I have worked with Novocure in the past and have a current ongoing research grant with them. Today we're going to talk about brain tumors in general just for a couple minutes and then dive into the treatments for glioblastoma and look at the mechanism of tumor treatment fields. We will then spend most of our time talking about the logistics of Optune and how to manage the most common side effects. So brain tumors are rare. I know many of you, your lives have been touched by brain tumors, and it seems like everyone knows someone who's had a brain tumor, but this is really an uncommon disease. When we look at the top 10 malignancies in the United States, the most common ones that we see are actually breast cancer and lung cancer, with about 250,000 newly diagnosed cases per year. The second in line is colon and prostate. And you can look at the top 10 list and you really don't see brain tumors on that list. Newly diagnosed primary brain tumors, there's about 80,000 each year in the United States, of which only 1/3 are considered malignant. To make this top 10 list of cancers and malignancies, you had to have around 40 to 50,000 newly diagnosed cases each year. So brain tumors are rare. When we look at the distribution of primary brain tumors, and by primary brain tumors, I'm talking about tumors that start in the brain, as opposed to metastatic disease, which are cancers that spread to the brain. But primary brain tumors, the most common adult primary brain tumor is actually meningiomas. These are benign disease. They often don't need treatment, and these are often unknown. The second most common primary brain tumor is the gliomas. When we look at the different types of gliomas, the ones that most people think about are the astrocytomas and the oligodendrogliomas. Ependymomas and pilocytic astrocytomas are much less common and typically seen in the pediatric population or the young adult. Looking at astrocytomas and oligodendrogliomas, we grade them on a level of 2 to 4. The low-grade tumors are in the grade 2 range. Anaplastic correlates with a grade 3 diagnosis. And then, unfortunately, the glioblastoma, or the grade 4 astrocytoma, is the most common primary adult glioma. When patients are diagnosed with a glioblastoma, most patients start out with surgery. Surgery has two purposes. One is to confirm the pathologic diagnosis, and second, surgery is often done to alleviate some of the initial symptoms that patients present with. After surgery, there typically is a 1-month break to recover from surgery, and then patients go on to start their treatment. Treatment, I will often divide into phase 1 and phase 2. Phase 1 consists of radiation that is 6 weeks long. It is given Monday through Friday. And along with that, patients will take a daily dose of temozolomide, an oral chemotherapeutic. And that's actually taken every single day, including Saturdays and Sundays. About 1 month after completion of phase 1, patients will undergo an MRI, and most often this is followed by phase 2 of treatment, which consists of adjuvant temozolomide. Adjuvant temozolomide is given for 5 days every 28 days, and that's considered to be 1 cycle. The initial studies with temozolomide actually showed that it improved survival compared to patients who had radiation therapy alone, and that survival benefit was on average of 3 months. Now, 3 months seems like a small amount of time, but I want to emphasize that this is an average. There are patients who do better and do live longer. But based on this approval or this improvement in survival, temozolomide received FDA approval in 2005. Thereafter, there were many investigational trials looking at other drug options, and unfortunately, those trials were negative. So what came next when we started looking at the treatment of glioblastomas? And this actually leads to Tumor Treatment Fields. Now, Tumor Treatment Fields, Optune, and Novocure, we often use these words interchangeably. To be clear about it, Tumor Treatment Fields is actually the technology that's the therapy that's being delivered. Optune is the name of the device, and Novocure is the company. So what are TTFields? TTFields are alternating electric fields, which are directed towards the tumor. The fields are created by these transducer arrays, which are worn on the head. In this picture, you can see the arrays in the right-left configuration, and they create a charge. And this charge alternates back and forth from positive to negative. That field is directed towards the tumor, and it flips back and forth about 200,000 times a second. There's a second set of transducer arrays, which are not shown on this picture, which are placed in the front-back direction. The way that the electric fields actually work is they disrupt cell division, and it acts upon these highly charged proteins within the cells. So to look at this a little bit closer, I think it's kind of easiest to start with normal cell division. So this here is a cell. Within it are chromosomes, which are depicted by these X's. And when this cell wants to divide into 2 cells, these chromosomes replicate. The next step is they will line up in the middle of the cell. And then there are these cables that will attach to the chromosomes to pull them in the right direction. These cables, which are also known as mitotic spindles, what's interesting about them is they are actually made up of electrically charged proteins. So these proteins, because opposites like to attract, will line up in a cable in this nice smooth line. The next step is that these cables will pull the chromosomes into the right cell, making sure that the right number of chromosomes end up in the right place. And then finally, you're left with 2 new cells with the chromosomes. Now, these chromosomes you can think about as the blueprint of the cell. They basically are there to tell the cell how to function. If these chromosomes don't end up in the right place, the cell does not know how to work. So let's take a look at what a tumor cell might act like when tumor treatment fields are applied. So this here is a tumor cell. I want to first point out that this cell looks very different than a normal cell, which is exactly what we see under the microscope. Tumor cells are often funny looking and they're bigger than what we typically see. The red lines here are the tumor treatment fields that are being applied to this cell. Just like a normal cell, when this cell wants to begin to replicate and divide, it will duplicate its chromosomes, and those chromosomes will line up in the middle of the cell. The cables will again form, but because there's an electric field that's being applied, these cables are not as smooth as they normally should be. If we go back up to this picture up here and we apply an electric field, those proteins suddenly become a little bit unstable and often will align with the field because it's a much more comfortable position for them. So you're now left with this cable that is broken and not quite as functional as it once was. What often happens at this state is because these cables are not exactly working the correct way, this cell will often arrest or go into a hibernation state. While the cell may still be present, it is not functional and it is not growing, which from a tumor perspective, we're happy with that. Now, some of these cells do go on to attempt cell division, but because those cables are not aligned properly, sometimes the chromosomes don't end up in the right place. This cell over here has 4 chromosomes versus this one over here has 2. They don't have the complete set that is necessary to go on to function as a cell, and that cell can often undergo apoptosis or cell death. So this is one of the mechanisms in which Tumor Treatment Fields works on tumor cells. There's many other proposed mechanisms that are being investigated. They actually have demonstrated this in vitro, looking at cell petri dishes. And you can find this video on their webpage. But this is 2 dishes of cancer cells, and on the left, the tumor treatment fields are applied. And on the right, there is no treatment that's being involved. And on the website, you can see the time-lapsed video. And about 48 hours later, you can see the control over here is full of tumor cells. However, this dish over here, while there still are tumor cells, they are far fewer in number. And also, some of these cells are funny looking. You can see here that there's some blebs, which is a sign of cell instability and cellular dysfunction. So this is some of the first data that we had that showed that tumor treatment fields did indeed work on cancer cells. The first human study that was done with tumor treatment fields was called EF11. And this was a multi-institutional study across 7 countries. The primary endpoint was actually looking at overall survival. This was a phase 3 study that looked at patients with recurrent glioblastoma. So all of these patients had surgery to confirm that they did indeed have a glioblastoma at their initial time of diagnosis. They went on to receive radiation and temozolomide, and that was followed by maintenance temozolomide. At the time of recurrence, patients who chose to enroll in the study were then randomized in a 1-to-1 fashion. And we had equal groups. Half of the group had received tumor treatment fields alone, and half of the group went on to receive physician's choice of chemotherapy. As many of you are probably aware, there is no standard of care when it comes to recurrent glioblastoma. And so they really left it up to the physician's choice, which reflects what we do in practice. So what this study showed was that the 2 groups of patients did absolutely the same. Now, when we look at clinical trials, we're used to seeing curves separate in order for the intervention to be considered a success. But this is actually a positive trial, because what it's saying is that patients that received tumor treatment fields here in the blue line did just as well as the patients who were receiving chemotherapy. The other thing that you can note is that there does seem to be a separation of the curves here at the end, but this was not statistically significant. One example that was shared in their publication of a patient who enrolled in EF11 is demonstrated here. And it makes a good point that many of these patients who were enrolled in this trial were actually heavily pretreated. So this was a 55-year-old gentleman who had a recurrent glioblastoma. He had standard upfront treatment with chemoradiation followed by adjuvant temozolomide. At his first recurrence, he received bevacizumab and irinotecan. At his next recurrence, he went on to receive erlotinib with sorafenib. After his third recurrence, he actually enrolled in EF11, and he was randomized to TTFields alone. This here is his baseline study, or his baseline MRI when he enrolled in the study, and you can see the tumor here. After 4 months of tumor treatment fields, there actually is regression of the tumor, and this was maintained till 12 months out, where there was near complete resolution of that tumor. So this was exciting to see. This is just one example of many patients who had a great response to tumor treatment fields. So what we learned from EF11 is that tumor treatment fields is as equally as effective as next best chemo for recurrent glioblastoma. The other thing that the study looked at was the toxicity profile and quality of life, and patients who wore tumor treatment fields actually had a favorable quality of life profile and actually seemed to tolerate treatment better than chemotherapy. The most common side effects reported was scalp irritation and headache, with the scalp irritation being the one that is attributed to tumor treatment fields. And then there's some other side effects. So with this study, the FDA approved the use of tumor treatment fields for recurrent glioblastoma. Now, the other thing that came out of EF11 was the PRIDE registry. And this was basically a data registry for any patient who was using tumor treatment fields at the time of recurrence. And the take-home message from this slide was patients who wore tumor treatment fields at least 75% of the time had survival advantage compared to those that did not. So this is the data that supports that the recommendation is to wear tumor treatment fields at least 75% of the time. 75% of the time equates to 18 hours a day. When you choose to do tumor treatment fields with Optune, you will actually be provided a compliance report. And this is just one example from one of my patients. The compliance report is sent to your physician. And what this shows is on a daily basis, it shows the days in red and nights in blue, and kind of will provide data sets for the past month. It will then average it, and this patient's compliance was excellent at 92%. I wanted to share this compliance report as well. This patient is doing very well as well. Her compliance is at 86%. But the thing to note here is that this patient probably took a long weekend trip somewhere and decided to only wear it really at night and not during the day. But because they were so compliant early in the month, their compliance average for the month was still at 86%. And so the important message here is that you can stockpile your hours. You can build up the hours. You want your average compliance for the month to be above that 75%. So you can still plan special weekend getaways, or if there's a family wedding coming up, you can take that day off and still maintain the recommendation for to remain therapeutic efficacy. This is another example of a patient who took a 1-week vacation and how that really can impact your compliance. So there was a 1-week break here over the holidays, which can commonly happen. When the compliance was generated for that 1 month, it was 57%. Now, I do believe the clinical trial did allow for 2 one-week breaks throughout the year. That is, vacations and time away is an important aspect of quality of life. So to have this on occasion is, probably acceptable, but to have this be a monthly report, month after month, would not be recommended. So like all things that work well at recurrence, we always ask the question, is this something that would be better to use in the newly diagnosed population? And so that led to the next clinical trial, which is EF14. This was a prospective multi-center trial of tumor treatment fields in the newly diagnosed GBM population. So all of these patients underwent surgery or biopsy to again confirm they had a glioblastoma. They received radiation and temozolomide up front. They then were randomized in a 2-to-1 fashion, meaning 2/3 of the patients were receiving tumor treatment fields with adjuvant temozolomide, while the remaining patients received adjuvant temozolomide alone. If we go back to our schema that we showed earlier in the presentation, this is what the treatment profile would look like. And the results from EF14 were positive. You can see here that the curves have nicely separated, and patients on average lived an additional 5 months. And again, that's on average. There are patients who do better than that. And there's a couple really important points from the conclusions from this study. The first is that this data is 5 years out. So this isn't initial data. This data actually sustained the duration of 5 years. The second is that the survival benefit was seen across all different patient populations. We haven't really touched upon MGMT methylation status, but I know many of you are aware of that, and that patients who are methylated have a better overall survival. The survival benefit with Tumor Treatment Fields was actually independent of the methylation status, which means patients who are unmethylated still derived benefit from wearing Optune. The other important aspects, the extent of resection, so whether you had biopsy only or gross total resection, patients still benefited, all ages, all performance status, and gender. So the results of this study, this was the first positive phase 3 study in the newly diagnosed GBM population in 10 years. So it was very exciting to see this in our field. So the conclusions that we can draw from EF14 is that tumor treatment fields added to adjuvant temozolomide improved the progression-free survival, which means the time to tumor recurrence, as well as the overall survival. The clinical trial also looked at quality of life, and it did not have any negative influence on patients using Optune. And the only main side effect that we really see is the itchy skin or the scalp irritation. When we look at some of these other side effects that was seen with use of tumor treatment fields and temozolomide, many of these side effects can be attributed to the chemotherapy as well. So based on this data, the FDA approved the use of tumor treatment fields in newly diagnosed GBMs. So just like EF11, they looked at the compliance data for EF14, and we learned a few things. The first thing is that compliance as low as 50% still provided some survival benefit, but the more important take-home message was that the greater the compliance, the better the outcome that we have seen with patients. And to demonstrate this, I put together this graph here. In terms of survival, this is, radiation alone. When you add temozolomide to radiation, the median survival improved by 3 months. When you looked at temozolomide, radiation, and tumor treatment fields in patients who were 70 to 80% compliant, that number increased by 5 months. And then if you look at this group way over here who had compliance rates of more than 90%, their survival was increased by 7 months. Now, this was presented at the Society of Neuro-Oncology meeting this past November, and the data is yet to be formally published. So this group over here, I call them my 90%ers because I do have a subset of patients that are in this 90%er club, and they do amazingly well. An important thing to note, though, is that sometimes because of the skin irritation, no matter how hard patients try, they just can't get into that 90%. But 85% is still good. And so as much as we want everyone to be in that 90%, some patients, because of the skin, just can't reach that. But there still is benefit. So to conclude some of the clinical trials, Optune is FDA approved in glioblastoma in adults aged 22 years and older. The reason it's age 22 and not 18 is because this is a device, and that's the cutoff that the FDA approved, that the FDA uses. So it is FDA approved for recurrent glioblastoma as monotherapy if additional surgery and radiation are not an option, and that we received FDA approval in 2011. And then it became FDA approved in the newly diagnosed glioblastoma population in 2015 when used with adjuvant temozolomide. There are a few contraindications. So if you have implantable medical devices, such as programmable shunts, cardiac devices, or vagal nerve stimulators, Optune cannot be used. Also, if there's any skull defects, because these arrays are placed on the scalp, if there's any missing bone, Optune is contraindicated. If there's bullet fragments in the head, that is a contraindication. And then if anyone has any known sensitivity to conductive hydrogels, which is on the array, that is a contraindication. And then finally, the recommendation is to wear Optune at least 18 hours a day, which is 75%. Also knowing that additional benefit is seen with higher compliance. So what are the logistics with Optune, and what is all involved with receiving this therapy? Well, once you decide to wear Optune, a device support specialist is assigned to you, and they will bring all of the stuff seen here on this slide to you, either in clinic or actually come to your home. So let's just kind of walk through all these different parts. The big one here is this is the electric field generator. This is the actual device, and it weighs about 2.7 pounds. This is the second generation device. The first generation device was much bigger, probably it was about 11 to 12 pounds. I do have to say I did see a significant increase in compliance on my patients who moved from the first generation to this lighter second generation device. So you receive this electric field generator. These are the batteries here, and this is the charging unit. You receive 4 batteries, and the battery actually slides here in this position. This is a power supply for when you are at home. Otherwise, patients use the batteries when they're out and about. There are 2 carrying cases that patients decide upon for various reasons. This here does have a shoulder extender to use it more like a satchel or a purse, and this is the backpack. Now, both of these carrying devices are specially vented to allow the device to have enough air circulation and remain cool. It is not recommended that you just throw it in the backpack, because if it doesn't have proper air circulation, the device will overheat. It will notify you, but you will want to try to avoid that. Patients will choose the different carrying options depending on their preference. Some women prefer the shoulder bag because it's similar to carrying a purse around. Others like the backpack because their arms are free, their hands are free, and they're not kind of pulled from one side to the other. So it's a very personal preference. These here are the arrays, and I have the underside of the array shown here, and you can see that each array has 9 ceramic discs in a row. This is what actually creates the electric field. This is a hard plastic that leads into the cord, and we'll talk about that in a minute. It's important to note that there are 2 black end arrays here and 2 white ends. They need to pair up when you place the arrays on the scalp. And then these array ends will then go into this clip here, and it's color coded, so you know exactly which place it should go in. This then clips into here, and the unit can be powered on. So this is the Optune system that patients are provided and educated. The device support specialists will educate patients and their support family about how to use it. And that training can take, on average, about an hour and a half. So one of the most important things with using Optune is preparing the scalp. Preventing infection is key. And while it seems sort of common sense, you want to wash your hands every time, and you also want to take your time. There is a learning curve when learning how to place the arrays. Patients will say on average it takes 45 minutes, but I've had others who have become masters at replacing the arrays where they can get it down to 20 minutes. And there's some who take a little bit more time, and that's okay. You do have to shave your scalp with using Optune. The recommendation is to use an electric razor because there's less scalp nicks and injury. Your scalp should be washed. We typically recommend a mild, fragrant-free shampoo, such as baby shampoo. You need to have alcohol. Alcohol is actually required to remove the naturally occurring scalp oils. And when you are wiping the scalp down, you want to avoid any areas that have a little bit of irritation because alcohol will make that worse. You don't need a lot of alcohol. I find that sometimes patients will overuse alcohol because they want to get it really clean. There's no reason to scrub the head with alcohol. A simple wipe is usually enough to suffice. And then transducer arrays. So these arrays are changed every 3 to 4 days on average. It really is individualized. It depends on how fast the hair grows and how much the head sweats. And that varies from one person to the next, and it varies on the time of year as well. You will often be getting increased alarms, and the increase in alarm frequency is kind of a sign that your arrays are not adhering as well. They are not connecting as well. It's probably time to change. As that hair grows and as the head sweats, it kind of pushes the array off the skin, and it doesn't make as good of a connection. Now, most of my patients say that the arrays come off fairly easily when it comes time to change it, but if you have any difficulties changing those arrays, you can use baby oil or mineral oil to kind of loosen that adhesive tape. And when you reapply the arrays, make sure again that you have shaved the scalp and that it's as close of a shave as possible. Another important thing is to make sure that the scalp is completely dry. And then the final thing is that the arrays should be shifted. Now, the device support specialist will explain that to you in detail, but just to give you a little bit of preview, every patient is provided an array map. And these array maps are individualized depending on where your tumor is. So sometimes the arrays will be shifted off to one side or the other. Now, some of your physicians can do their own array maps, and they will do measurements on an MRI, submit it to a computer program to generate these maps. Other physicians will send the MRI into NovaCare and have it done by them. Whoops. Sorry about that. So again, these array maps are individualized to the patient. A couple things to point out. One is they will actually show you some dotted lines where you can cut the array. This array is positioned closely down on the scalp, and sometimes patients will want to try to trim that so they don't have as much showing. The other thing is that the array positioning can often change. So in this patient, it's positioned the long way, but in some patients, it actually will be positioned side to side. And then just to give a little information on how you shift arrays. For this patient, with the next array change, this array would be moved forward while this array would be moved back. You want to move everything in parallel, and these two would be shifted kind of up, down in this direction. And usually we recommend shifting it about 1 centimeter or the one disc shape. And oftentimes patients will have an A pattern and a B pattern, so they'll just kind of rotate back and forth. And the purpose of this is really to give the skin a little bit of break from having that direct contact of that disc. So what are some common concerns I hear from patients who have decided to do Optune or are considering it? Well, the first is you can bathe or shower, but you can't do it while plugged in. Water should be avoided at all costs. You are provided a shower cap. What patients will often do is they will unplug from their device, they will wrap the cords up, tuck it in the shower cap, and then go on to take a shower or a sponge bath. And then when they change their arrays, they'll go take their heavy-duty shower and clean their scalp really well. You can wear head coverings. So some of my patients choose to wear nothing at all, while others will wear a hair prosthesis or a wig. It's important to note that if you are considering wearing a wig with Optune, you should wait until you have the device on before having your wig fitted. You will want to have a little extra room for the wig to allow enough air circulation around the arrays. Other patients choose to wear a light loose-fitting head wrap or even a hat. I've seen many patients wear a hat that has a little bit of ventilation in it. So head coverings are definitely acceptable. You can travel. So Novocure has a program which is called Encompass. Encompass is actually their support line for basically any questions, but they have assisted many of my patients in traveling to all parts of the U.S. And can be really an asset of how to get through security at the airport. If you are having any kind of x-rays, CT scans, or MRI scans, you must remove the arrays from your head. Early on when we were using Optune, I had a patient that came through the ER, and this was an example of the sort of x-ray that was done before the CT scan, and you can see the discs here. When they actually did the CT scan, this is what you see, and you can see nothing in terms of the brain, and that's why we need the CT scan. So that patient went on to have the arrays taken off, and you had a much better picture of what's going on in the brain in that case. So again, the arrays need to be taken off just so we can actually get good pictures, but also from a safety perspective. There are metal components within the arrays, so MRIs would certainly be problematic. So what to watch for? Skin issues is by far the most common thing that needs to be monitored. The things that we see most commonly with skin issues is dermatitis, ulcers and erosions, and then infections and folliculitis. And we know that there's a subset of patients that are at higher risk of developing these skin issues. One of the risks is when one of those ceramic discs are placed directly over a scar or any of the craniotomy hardware. The recommendation is to try to avoid that, but sometimes there's just no way to do that. And so that situation is a little bit higher risk of skin breakdown. Another risk factor is if there's any history of contact dermatitis to any tape adhesives or hydrogels. Another really common one is hyperhidrosis or excessive sweating, and this can really vary with whether if the patient is sick with a fever or if you're wearing any occlusive head coverings. High-dose systemic corticosteroids also places a patient at higher risk of infections in general, and that's no different with the skin issues that we can see. And then lastly, any patients who are receiving any sort of systemic anti-cancer treatment, there is a higher risk of skin issues. So some examples, looking at contact dermatitis and allergic dermatitis. So dermatitis simply means inflammation of the skin. And you can see that on this picture here, where you can see some red spots from this patient who is using Optune. We divide dermatitis into kind of two forms. Contact dermatitis is simply chemical irritation from the hydrogels or from the moisturizers or alcohol. So if you start to see dermatitis, one of the things you should ask is, are you using too much alcohol when you're preparing the scalp? The second type of dermatitis is allergic dermatitis, which is allergy to tape or hydrogels. And then dermatitis can worsen just with prolonged use, warmer temperatures, changes in humidity, and increase in sweat. So one way to try to prevent dermatitis or improve dermatitis is to change the frequency of the array changes. Erosions and ulcerations is basically due to mechanical trauma, often from the either from shaving or from the pressure from the array. And so I had pointed out this white insert here on the array before, and this is a hard plastic that then leads into this wire. And what can often happen is when patients are sleeping at night, they roll over and they put a little bit of tension on these cords, and then this presses into the scalp. And while it doesn't seem like it's, doing much, but if you have that pressure hour after hour while sleeping, that can sometimes lead to some erosions, which I have some pictures coming up. The other is the ceramic disc, which if you have pressure on top of that, so if you have an occlusive head wrap, that can put some additional pressure on those discs, or even sleeping at night, if your head is down, you can sometimes see that. We have to be careful with ulcers because you get decreased blood flow to the area, and then that can lead to significant increased risk of skin breakdown. And again, you have that hardware, that surgical hardware that we talked about as being a risk because that's direct pressure. So this is an example. The picture on the left is a mild erosion that a patient of mine had started to develop just due to some pressure from the array. And then this patient here on the right actually developed an ulcer with pretty deep skin involvement there. It's interesting to note that that patient's incision is going right through here, and so there's probably some of those risk factors that we had talked about before. My patients have managed erosions and ulcers in some common but slightly different ways. So many of my patients will use gauze pads and cut a small piece to put over that erosion before putting the array down. Now, it's very important to note that this cannot be under the ceramic disc. It would only be if this this adhesive portion. So basically what this is doing is it's preventing the adhesive of coming in direct contact to that skin and hopefully allowing that skin to heal up a little bit better and a little bit more quickly. Another process that my patients have used is that you can actually get some foam pads that provide a little bit of cushion. And remember, we talked about that plastic insert here. You can cut a little bit on either side to give a little bit of more give to this cord. You cannot cut through the disc, you cannot cut through this metal portion, but this white portion you can. And then what some of my patients will do is they will take one of these little pads and put it underneath, and it provides just a little bit more cushion so that if there's pull on the cords, it's not going directly into the scalp. So those are just a couple ideas that I've seen used in clinic. Folliculitis and infection, so simply, folliculitis is inflammation of the hair follicles secondary to infection. This is a picture here. If you get these little red bumpies or these red and white pimples, that's a sign of infection that has to be managed. So managing these skin complications, prevention is key. It'd be best to not have to worry about any of these. When we see dermatitis, though, we will often use a high-potency topical corticosteroid, which is applied with each array change. So the patient will take the arrays off, they will apply the corticosteroid, leave it on for 30 minutes, and then wipe that off. When we get to erosions and ulcerations, we can often get by with just a topical antibiotic, but if it gets too severe or too significant, patients actually have to take a break from their treatment, and we really want to avoid that. So we want to catch the erosions at the early state and avoid the deep ulcerations. And then when we see infections, we culture them, and then we'll use a topical antibiotic. Sometimes with infections, if it's severe, we will have to use oral antibiotics. Important factor too is you want to avoid any direct contact of the disc and the adhesives with any skin irritation. So keep in mind of using those skin protectors that we talked about. So other things to watch for, I think the second most common thing that I see is heating issues. During the winter months, it's not as big of an issue, but with summer approaching, a lot of my patients turn to using cooling pillows, which help at night. It helps keep their head just a little bit cooler. They also have cooling towels that the athletes use that my patients will wrap around their neck to just try to stay cool. Patients will often use a fan to blow on their head while sleeping at night or sitting during the day. And then an important thing too is when you are outside, you should really avoid direct sunlight because that can result in overheating. And the device will let you know when it's overheating, but that also requires you power down and cool off and then get back on. So we want to avoid time off. Lastly, you need to avoid water. Arrays should never get wet. If your arrays get wet, you should turn the device off and then change the arrays. So I gave a lot of information today, and it can be very overwhelming to sort of understand how Optune can fit in your life. I really recommend you find support. So there is a support group. So we have a support group at the Medical College of Wisconsin that meets regularly, and a branch of our support group is actually an Optune specific support group that meets. And this is actually a recent photo of our Optune support group. And what I learned by going to attend these is I learned all of these little tips of and secrets that the patients have learned through their daily exposure to using Optune. It is, I think, really helpful to hear from an Optune user what has worked for them, what hasn't worked for them. What most patients will say is that that first month on Optune is a lifestyle adjustment, but that many go on and they say it just becomes a normal part of their daily life. I have many patients who work with Optune, and they share how they're able to accomplish that. I have many patients who travel, patients who exercise daily. So there's all sorts of things you can learn from other patients who have used Optune. So find a support group. If you don't have a support group, ask your physician. I know my Optune patients are always more than willing to talk to someone else who is considering Optune, and that's been very helpful. So ask your physician if they know someone else who would be willing to talk to them. And then the caregivers. So the caregivers who are applying the arrays often want to connect with another caregiver. So support groups are very valuable. There are other opportunities to buddy up. So Optune has their own buddy program, which you can find online. The ABTA also has a mentorship program where they will take the treatment that you're on and your tumor diagnosis and try to identify a mentor that is in a similar experience or who has gone through a similar experience. So if you're thinking about Optune or using Optune, you could be paired up with someone else who has been using Optune as well. And then they have caregiver support matching through that program too. And then finally, there's social media. There's all sorts of support on the internet that you can find, whether it's Facebook or some of the other programs. So what's the future of tumor treatment fields? Well, there's certainly a lot of research that's going on with brain tumors and tumor treatment fields. When I looked a couple weeks ago, there were over 20 active clinical trials looking at tumor treatment fields. They are looking at additional GBM studies. They are starting to look at high-risk oligodendrogliomas. It's being used in the pediatric population, so looking at pediatric high-grade gliomas and ependymomas. And then more recently, we're looking at brain metastases secondary to lung cancer and whether tumor treatment fields can be effective at controlling that disease. The other thing is tumor treatment fields is starting to move outside of the brain. So they are doing clinical trials now in looking at non-small cell lung cancer and another type of lung cancer called mesothelioma, where they actually have thoracic arrays to wear on the chest. And then they're starting to use abdominal arrays when looking at pancreatic adenocarcinoma and ovarian carcinoma. So tumor treatment fields is moving beyond the brain tumor world, which is always exciting to see other treatment modalities in the fight against cancer. So in conclusion, tumor treatment fields is as effective as the next best chemo in recurrent glioblastoma. It improves progression-free survival as well as overall survival in the newly diagnosed glioblastoma population. It has a favorable toxicity profile, with skin irritation being the most common thing that we see. It is not associated with a decline in quality of life. And it holds promise for the future in the treatment of brain tumors as well as systemic cancers. So thank you for joining us today, and I think we will open it up to questions.
Thank you, Dr. Connelly. We will now take questions. We have a couple of minutes. If you have a question that you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. One of the first questions that we have for you, Dr. Connelly, is whether or not Tumor Treatment Fields is able to be utilized in treating anaplastic astrocytoma grade 3, and whether or not there's any research into this particular tumor type.
So that's a great question. Currently, Tumor Treatment Fields is not FDA approved for the anaplastic grade 3 population. I'm sure that there is ongoing research that's being done. I do not know of any specific clinical trials that is looking at upfront use in the anaplastic astrocytoma population. I do know that in the recurrent anaplastic astrocytoma population, I have been able to utilize Tumor Treatment Fields because oftentimes those grade 3s, when they recur, become a grade 4. And radiographically, we can call it a recurrent malignant glioma. So currently not FDA approved.
Thank you. Our next question is, which gliomas are considered to be high-grade or low-grade tumors?
So gliomas are often on a spectrum, but the low-grade gliomas is considered grade 2. High-grade gliomas, which are also called malignant gliomas, are grade 3 and grade 4.
Thank you. And our next question, how many months post-surgery or tumor recession do patients in these trials usually start using Optune?
So in the newly diagnosed population, most patients will start radiation therapy about 1 month after their initial surgery. They will go through the radiation with the daily temozolomide and then have a 1 month break while they recover from that treatment. And so it is after that 1 month break that patients will start the Tumor Treatment Fields with the adjuvant temozolomide. So it is about 3 months after surgery that patients start to use Tumor Treatment Fields.
Thank you. And we got a couple questions. I'm not sure if you have any guidance on whether or not health insurance or Medicare is starting to cover Optune.
So health insurances are starting to cover Optune now because it is part of NCCN guidelines. and I am seeing more and more healthcare companies covering it. Novocure helps going through the authorization process, and it will work with us to appeal to health insurance companies. And if if a patient does not have a company that covers Optune, there's a compassionate use program or a patient assistance program. I take that back. A patient assistance program that Novocure will help those patients receive the treatment.
Thank you. And maybe one of our last questions, can a patient with a cochlear implant use this device?
That is a great question. I do not know the answer to that. I would have to look into that. I have not had a patient with a cochlear implant, so I haven't crossed that path yet.
Okay, thanks. I will make sure to follow up with everybody with that one. And last question, what are the first steps one should take if they were interested in starting to use Optune?
So the first step is finding a certified provider who can prescribe Optune. In order to prescribe the device, you have to go through a training program through Novocure. If you go to the Optune website, it lists out all the certified centers and providers. And so that would be the first step, to meet with that provider. They can review your history and see if you are a qualified candidate for the device, and then get the process going at that point.
Great. Thank you very much, Dr. Connelly. That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Connelly for her wonderful webinar presentation.
Thank you, everyone.
Thank you. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, please visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.